All right, good evening, everyone. In the previous recording, we started revising Mrcs Part A, and we started with the shoulder bones. As you can see, I gave you a task to cover in my previous recording that you will be identifying these markings, and you'll be telling me what are the structures which are attached here, their origin and insertion, nerve supply, and action. I hope you would have covered all this in this recording. I will be giving you the answers. First of all, my question was how the shoulder girdle is formed. So I'm sure you'll be able to tell me what are the bones which are involved in the formation of the shoulder girdle, or it is also called, what is another name for it? Who is going to write and tell me? Pectoral girdle. Pectoral girdle or shoulder girdle. So it's the clavicle, this bone over here, and it's the scapula, this bone over here. They form the shoulder girdle. As you could see, this is the head of the humerus, and this is the glenoidal cavity. They are forming another joint. You would have to tell me which joint is this, glenohumeral joint, what type of joint is that, and what's happening. I'll discuss that with you people later in the later recording. So keep following me. Now I'll just give you the answer. Number one, you can see it's pointing at these two arrows. As a whole, this is acromion. So this is acromion. Number two, you could see here, it's the greater tubercle of humerus, right? What are the structures which are attached at greater tubercle? You would have to tell me. Number three, you can see here, because if this is greater, then something lesser has to be there. So this is lesser tubercle of humerus, right? Number four is here. This space is called intertubercular sulcus. So this space is intertubercular sulcus. Moving down, this is the shaft of the humerus. Number five is pointing at two dips. These are called condyles, the medial and the lateral. Okay, these are the condyles. Number six is capitulum. Right, capitulum articulates with the bone below to form elbow joint. Which bone? We'll come to that later. So number seven is also one dip. This is called coronoid fossa. What is the clinical significance of coronoid fossa? You're listening to the questions, find them out and learn them. That's how we are going to learn or revise or practice for the, or prepare for the Mrcs Part A exam, right? All the MCQs come from here. You have to know that. So this number 8 is pointing at something. It is called glenoidal cavity of scapula. See? So it's 8 is here. Number 9 is pointing at the inferior angle of the scapula. This is the inferior angle. This angle comes at what level? What are the landmarks of angle of inferior angle of scapula? Find that out, and once you are listening to this recording, write it in the video, answer it for me so that I know that you're following and you're listening and you're revising and practicing at the same time. Number 10, this one, it's subscapular fossa. What are the structures which are attached here? Subscapular fossa, right? And number 11 is here, coracoid process, right? So what is about the clavicle? What is the most common thing about the clavicle? You have to tell me. The most important or the clinical significance of the clavicle is that it's most commonly fractured among children. and it's mostly it gets fractured when they fall on outstretched hand or because of the direct trauma to the clavicle. It can easily get fractured. But the most weakest point is this is medial 2/3 and lateral 1/3. So between medial 2/3 and lateral 1/3 is the most commonly occurring point where, or the most weakest point where fracture occurs. As you know, in children, complete fracture never occurs. It's always the green stick fracture that takes place. So this is something that you have to remember. One more thing, scapula hardly gets fractured otherwise, but it's normally, or it can get normally fractured with the direct trauma. Whereas the humerus can get fractured at several places. Most importantly are, if you could remember, that it can be fractured at the surgical neck of the humerus, which is very important. It's just the region below the lesser tubercle. This is lesser tubercle and this is the surgical neck of the humerus where it can get fractured. And the significance is here is that when it gets fractured, then it can injure axillary nerve, which is a branch of brachial fractures. We'll come to that. We'll revise that later. So now I'll move on to the picture 2 that I asked you all to revise the other day. So I'm going to go and get that out. Now this is the posterior view, and now we'll compare how posterior view is different to anterior view. So look at number 1. It's the clavicle. Now they are labeling clavicle from the behind, from the posterior. Number 2 is the suprascapular notch. See here, notch, dip. So what are the significance of these? You have to read it, find it out, and let me know. Otherwise, we'll discuss it in next recording or next revision. Number 3 is the superior angle. See, before we studied inferior angle. So whenever there is inferior angle here, there has to be one superior angle as well. That's the easiest, most way of learning something. So number 4 is the supraspinous fossa. So if it's supraspinous, something has to be infraspinous as well. So this number 6 is infraspinous fossa. What muscle attaches here and in supraspinous fossa? What are their origin and insertion? What are their nerve supplies and what their action or mode of action is? And number 5 is the spine of the scapula, right? Now moving on to 7. 7 is the medial epicondyle. What's the clinical significance of medial epicondyle? Yes, it's related to ulnar nerve. When that is compressed against the medial epicondyle, you feel that tingling sensation. I'm sure you remember that. You've experienced it sometimes in your life. Right, moving on to 8. 8 is trochlea. Right. Number 9 is olecranon fossa. See, that's the fossa, depression. Number 10 is the deltoid tuberosity. Why is it called deltoid tuberosity? Any clinical significance of it? 11, that is the head of the humerus, right? That's the head of the humerus. Right, what more I can tell you? About clavicle, one more thing if I can tell you. That's the first bone, which is to be ossify in the human body. But the last bone to fuse it, and it's the mostly formed in the intramembranous ossification. Right, I already told you that is most commonly fractured. Mid shaft of the humerus, let me tell you where deltoid tuberosity is. That's the point of insertion of the deltoid muscle, right? That's why it's called deltoid tuberosity. Distally, if I tell you depression above the trochlea, this is trochlea and this is the depression, right? Olecranon fossa. It accommodates the olecranon process of the ulna when elbow is fully extended. So this is something that you have to know. Right, I already told you about the fractures of the surgical neck of the humerus, and I told you in the previous picture that surgical neck of the humerus is below the lesser tubercle of the humerus. So what happens that whenever surgical neck is fractured, that injures the axillary nerve of the brachial plexus. So one has to be very careful. Whereas in the mid shaft of the fracture of the mid shaft, it's the radial nerve which can get injured whenever there is a fracture of the mid of the shaft of the humerus. So 3 nerves, humerus is very important, you have to know it. Surgical neck of humerus, let me repeat again, axillary nerve. Mid shaft, fracture of the mid shaft of humerus, radial nerve. Medial epicondyle fracture, ulnar nerve, right? So I am sure you would have gotten that straightened up by now. In the next recording, we will discuss the muscular attachment in this region and all the ligaments and all the important structures which are attached here, clavicle, scapula, and humerus. All right. Until then, keep revising. Keep revising, because what I say, that practice makes you perfect. Right. Thank you.